Now let's have a discussion of entirely new topic, that is pediatric orthopedics. Under this section, we are going to talk about the diseases related to musculoskeletal system in case of children, and out of some of the diseases, some of them are going to be developmental abnormalities. Now the first one, or the first topic that we are going to begin with, is a Sprengel shoulder. Now first of all, try to understand what is a Sprengel shoulder, and then it would become much easier for you to identify this Sprengel shoulder abnormality. So Sprengel, that is a Sprengel shoulder. So what exactly is a Sprengel shoulder? It is incomplete descent of scapula, also known as high-lying scapula. So Sprengel shoulder is incomplete descent of the scapula, also known by the name of high-lying scapula. Now what does it mean? What happens is that during the 5th intrauterine week of the life, the scapular primary ossification center is developed in the cervical region. All right, primary ossification center of the scapula is developed in the cervical region, or is originated in the cervical region. And from this week up to the level of 3 months of life, it descends down, all right, to reach the final region in the thoracic wall, posterior wall of the thorax. Imagine if there is any abnormality through the process of this descent, as a result of which the scapula remains higher in comparison to the normal. This is what a Sprengel shoulder is. So what is a Sprengel shoulder? It is incomplete descent of the scapula, or simply high-lying scapula. This is what the Sprengel shoulder is. Now, what you have to understand under this particular topic are the associations. Means what are the other conditions with which it could be associated. Now, one of the other developmental abnormality it could be associated with is Klippel-Feil syndrome. So what is Klippel-Feil syndrome? You will come to know exactly about the Klippel-Feil syndrome in the subsequent topic. But yes, it is another condition with which it could be associated. Now, other than this Klippel-Feil, there are, there is indirect connection of the scapula with the vertebral column, with the ribs, as a result of which there could be primary or secondary abnormalities of the vertebrae and the ribs associated with this Sprengel shoulder. So one of the abnormality could be a kyphoscoliotic abnormality. So it can result in kyphoscoliosis. There could be a crowding of ribs associated with this. That means abnormality of ribs. And diastomatomyelia. Even the structural changes in the spinal cord. So these are the associations along with the Sprengel shoulder. Now, how will you identify a Sprengel shoulder on the given image? You see, this is the normal level of the scapulae. This is a normal level. But here what is happening? It is a high-lying kind of the scapula. That means which is present above the level of the normal scapulae. This is how you will identify. Now, one of the very close differential diagnosis of this Sprengel shoulder is winging of scapula. Means you can get it confused with that there is a possibility that I am looking at the image of a winging of a scapula. But how to differentiate it from winging of a scapula? Because in winging, the level of the shoulder or the level of the scapula, both of them are going to be same. It is only that the medial border of the scapula would be more prominent in winging of a scapula. While in case of a Sprengel shoulder, what is happening? That the level of the scapulae is different. On the affected side, it is relatively higher. And what are going to be the clinical features for the purpose of its identification? Mean, how will you identify this Sprengel shoulder on a given image, or what are the features? One of the feature is the difference in the level of scapulae. So this is what the definition of the Sprengel shoulder is. Second is that it will be a broad kind of the scapula, but it is relatively a short scapula. So although the scapula which is abnormal is shorter, but because of its malrotation, it will appear wider. So if you look at the breadth of the scapula, it is wider in comparison to the normal one. But overall, the dimensions of the scapula are relatively smaller in comparison to the normal one. So it is short and wide kind of the scapula in comparison to the normal one. And finally, there will be a limitation of shoulder abduction. So why there will be a limitation of shoulder abduction? Because up to 90 degree, it is a pure movement happening at the level of glenohumeral articulation. But beyond 90 degree, the shoulder abduction is assisted by external rotation of the scapulae. Now, if the scapula is abnormal in location or position and its morphology overall, so there will be a limitation of shoulder abduction also. So these are the clinical features related to this particular topic, that is sprangle shoulder. So what are the 3 points which you need to remember related to this particular topic? Point number 1 is the definition itself, that it is a high-lying scapula. You came to know the reason, but obviously no one is going to ask about that particular reason. Point number 2 is that what are the associations? One is Klippel-Feil syndrome and the secondary structural changes in the thoracic bones. And the third part is the clinical feature, that what are the associated abnormalities related to the functioning of that particular joint. So it is a limitation of shoulder abduction, which is particularly important for you to remember in a sprangle shoulder. And finally, the identification on the given image. One of the scapula will be higher in comparison to the normal. This is how you will identify a sprangle shoulder case. So that is the first topic in pediatric orthopedics. The second one is Klippel-Feil syndrome. Now, what is Klippel-Feil syndrome? It is actually a developmental. Means, what is the definition of Klippel-Feil syndrome? It is the developmental or congenital fusion of 2 or more than 2 cervical vertebrae. When 2 or more than 2 of the cervical vertebrae are fused congenitally, then this is known as Klippel-Feil syndrome. All right. So this is the basic abnormality. Now, what it will lead to? It will lead to a triad of, there are going to be 3 clinical features because of this Klippel-Feil. One is short webbed neck. Now, it is not difficult to understand that out of the 7 vertebrae, if 2 or more than 2 of the vertebrae are fused, then it will result in the shortening of the neck. Point number 2 is, and there will be webbing of the skin also. Point number 2 is low posterior hairline. Now, it is again not very difficult to understand that the posterior hairline is usually occipital, but when the neck is relatively shorter, then the posterior end of the hairline is going to be reaching or at the lower level. That means involving the half of the cervical or up to the base of the cervical region. So low posterior hairline. And finally, there will be a limitation of cervical movement. Now, it is not very difficult to understand that why the cervical movements are going to be limited. The cervical movements are nodding, that means saying yes, saying no. So these are the movements along with the lateral flexion and lateral bending. So these are the movements at the cervical spine which are happening at the various levels of the vertebral column or the vertebrae. If 2 or more than 2 of the cervical vertebrae are fused, then there is expected limitation of the cervical movement in case of Klippel-Feil. One of the association of Klippel-Feil syndrome is the sprangle shoulder, which we have already talked about. And this is exactly what the Klippel-Feil syndrome is. And if you look at this picture, this is how you can identify to some extent, although no picture is going to be provided to you in order to identify this particular question, that is Klippel-Feil syndrome. All right. What all you need to remember are the clinical triads associated with this syndrome in particular. So this is all about your Klippel-Feil syndrome that you have to remember. Now, point number 3 or the topic number 3 related to this pediatric orthopedic is torticollis. Now, all of you are aware of the fact that what is torticollis? Torticollis actually is a wry neck. Wry neck means bending of the neck. So it is a congenitally bent neck. When a child is born, he is having a congenitally bent neck, that is known as torticollis. Now, how it is important, torticollis? Point number 1. The etiology. What all you need to remember under this heading of torticollis, point number 1 is etiology. All right. What are the causes? Now, as far as causes are concerned, there could be a muscular cause, there could be a bony cause, and there could be a combination of both muscular as well as bony cause. All right. That means musculo-osseous etiology. Now, what you have to remember is the muscular contraction. Now, one of the muscle which get contracted on the affected side is the sternocleidomastoid. So, most commonly isolated etiology responsible for this torticolic abnormality is sternocleidomastoid contraction. All right. As I told you that the etiology could be muscular, it could be osseous as well as musculo-osseous. What you have to remember is the muscular abnormality. Particularly, you have to remember the name of the muscle which is responsible for causing this torticolic abnormality. That is point number 1. Now, the point number 2, which is again very, very important, is the associations. That what are the other conditions with which this torticolic abnormality could be associated. So one of the association is DDH, that means developmental dysplasia of hip. We are going to have a discussion on this association later. We will be talking about the importance of this association later. But at this point of time, you just remember that torticollis is found to be associated with DDH. And point number 2 is metatarsus adductus. All right. When all the metatarsus are added, it is again a congenital abnormality, where the morphology of the metatarsals is disturbed, where there will be a bending of all the head of the metatarsals towards the midline of the body. So this is metatarsus adductus. So, you know, if a child is presenting to you with the torticolic abnormality, it is important to screen this child for developmental dysplasia of hip. All right. So this is what you have to remember. By putting a star, you can mention it that screening of a child is mandatory. Screening for developmental dysplasia of hip is mandatory in a child suffering from torticollis, because torticollis is an abnormality which is very clinically evident, but DDH is something which is not clinically evident in majority of the cases until and unless there is a dislocation happened. But this is something what you have to remember, that because it is found to be associated with it, whenever you see a child with the torticolic abnormality, screen a child for developmental dysplasia of hip also. So this is what you have to remember about the associations. Now point number 3rd, or the point number C under this heading of torticollis is the treatment. That means management, that how will you treat this condition. The treatment is either unipolar or bipolar release. Now, what do you mean by the term unipolar or bipolar release? You know, sternocleidomastoid is contracted. The name sterno because it is having one attachment at the sternum. Cleido, one attachment at the clavicle. Mastoid, one attachment at the mastoid process. So, sternocleidomastoid contractures. Now, unipolar means when you erase just the clavicular end or the mastoid end, and by erasing or by elevating this this insertion or origin of the sternocleidomastoid muscle, if all the deformity is corrected, then it is called as unipolar release. Bipolar release means that if you have erased one of the attachment, the entire abnormality is not corrected, so you have to erase the second attachment also. So that will be called as bipolar release. So unipolar or bipolar release, it is not important for you to remember that what is the name of the attachment that has to be erased or released, but it is important that at what age this release has to be performed. So this unipolar or bipolar release is optimally performed at 1 year of age. It is best performed or optimally performed at 1 year of age. So these are the 3 things that you need to remember under the heading of this topic, that is torticollis. Identification is important. When you see the x-rays, or sorry, when you see the image, one of the end of the neck will be bent towards the affected side while the chin will be pointing towards the opposite side. So this is how you will identify a torticolic unipolar, that means unilateral torticolic abnormality. Point number 2, the etiology is important. Point number 3, the associations are extremely important. And point number 4, the management of torticollis, which you should be knowing that the optimal age for the performing these management is the 1 year of age. Then comes the 4th topic under the heading of pediatric orthopedics, and that is neurofibromatosis type 1. You know, this is a kind of a topic which is very commonly asked in the form like, all of the following are the features of neurofibromatosis type 1 except. So we are going to have a discussion on the key clinical features of this neurofibromatosis or NF1, neurofibromatosis type 1 abnormality. But before talking about the clinically apparent or clinically abnormal conditions associated with this, It is also important to remember that what is the other name which is given to this. So this condition is also known as von Reckling